Thank you, sir. And the topic on which I would be speaking is managing pre-existing PC defect. So we'll start with a pediatric eye, and what you see here is a posterior lenticonus, and which is very clear uh, um, on examination. So no doubt about it. So important is don't do any hydro procedures, none of it, because we want to aspirate all the cortex without any vitreous loss. So without hydro procedures in children, it is quite easy, and always take care not to decompress the eye suddenly, because that will be a trigger for the vitreous to come in the anterior chamber. So as you see, it's gone on smoothly, and with such a large defect, the choice is ours. Either we can put a three-piece lens in the sulcus, or in this case, I could have very well tried a single-piece lens in the bag also. So anterior vitrectomy is done as we do in all pediatric cataracts, and then the lens is pushed gently. It is a three-piece lens which is gently dialed in the bag. So easier, since I use a lot of three-piece lens, for me it has become a practice, but easier would be a single-piece lens in the bag. And then without just a gentle wash of the AC using cannula helps in avoiding vitreous loss. Second scenario in pediatric patients is a blunt trauma leading to a PC defect, and you can see the line of the posterior capsular defect through the total cataract. So again, avoid hydro procedures. Why I have included this video is I'll show you the error that happens when you are not careful. Cortical aspiration went off very well and without any vitreous loss, and here I come out suddenly, and what you see is vitreous popping up. And then also not realizing the mistake, the IOL is being implanted, and when you dial, it is not going. So and this all should be avoided, because this will lead to vitreous traction, and further posterior segment complications can happen. So this is the lesson learned: never decompress suddenly. And after realization, I went with the cutter, removed the vitreous from the bag, and it's a very high speed cut rate. So if you see here, you cannot see the plunger moving itself. Once it is done, then IOL will very comfortably dial and placed in sulcus. And then pilocarpine ensures that there is no vitreous, and another thing what we can use is triamcinolone. So third case will be adult case, soft nucleus. You can see the large posterior polar cataract in it, and that is when you do, in these cases, what I do only hydrodelineation, no hydrodissection. So small nucleus with hydrodelineation can be demarcated, and the nucleus comes out. Phacoemulsification done, but you are left with a large plate. So that plate, without ensuring removal of the plate without much disturbance, because we don't want any vitreous disturbance in such cases. And a funny story about posterior polar is that first 3-4 years of my career, I didn't have any PC rent. So in posterior polar cataract, then I boasted to one of my colleagues that I have not had it ever. And after that, I had next week, and I have been having it very frequently. So while doing the cortical aspiration, till now all going fine. And we are taking care not to decompress it because of the lesson learned from the last case. But still, with all precautions, posterior polar cataract may sometimes give way, and our aim is that no vitreous loss. So here you can see a linear PC tear has occurred, and so the lens has been placed in the bag. In the sulcus with optic capture. And gently clean the visco from the anterior chamber without using irrigation, just a normal saline wash. Now coming to the last case, which is a harder grade nucleus, almost an NS3. So in this case, I took precaution that I made a slightly larger rhexis, because we want minimum manipulation of the lens. So a 4.5 millimeter rhexis may cause problems. So I went for a 5.56 millimeter rhexis. Gently with a spatula in the beneath the anterior capsule, if you sweep it, that ensures some mobility of the lens. And then slowly you start chopping it into small pieces, and goes on smoothly till now, and you can see the posterior polar intact there, and this is the stage in which we have to avoid decompression and start doing gentle cortical aspiration. And while doing the cortical aspiration, what we see that pupil is going down, pupil is becoming constricting. And with lesser visibility in such cases, better not to take chances. The iris hooks are used for expanding the pupil, and then the cortical wash restarted. And here you go, the linear PC rent identified. But again, if you are gentle and if you are careful, there will be no vitreous loss. And good red glow is very important in the microscope for these cases, to identify it at a proper time, with AC decompression avoided, lens placed in the sulcus, and gently dilated, dialed in the sulcus, no vitreous loss, and remove the hooks. Don't do a irrigation aspiration at the end, just wash the AC with a cannula. And you get a good round pupil at the end of the surgery. Thank you so much.